I'm wishing all you lovely women out there and myself a very good evening. I'm wishing all you lovely women out there and myself a very happy International Women's Day. On behalf of Jaslok Hospital and Voice of Healthcare, I warmly welcome Honorable Ms. Aditi Varda Tatkare, Minister for Women and Child Development, State of Maharashtra, respected keynote speaker Dr. Daksha Shah, Executive Health Officer, Municipal Corporation of Greater Mumbai, Mr. Jitendra Haryan, CEO, Jaslok Hospital and Research Center, Dr. Naveen Nishchal, Chairman, Voice of Healthcare, Dr. Firoza Parekh, Director, Assisted Reproduction, and her esteemed panelists, Dr. G.N. Mansukhani, Director, Gynecology and Obstetrics, with her esteemed panelists, VOH team, Jaslok Hospital, and all your lovely audience there to the fourth edition of Bett-Her Health. We will kickstart the event. Before that, let me tell you all a little about Jaslok Hospital and the Voice of Healthcare. Jaslok Hospital and Research Center is a super specialty tertiary care private hospital that stands tall in India for the past 50 years for its patient centricity, clinical excellence, and research-based approach. Jaslok Hospital was established in the early 1970s by a philanthropist, Shri Seth Lokamal Chandrai and Srimati Jasoti Bai Chandrai. Dr. Shantilal Mehta, the doyen of medical profession in India, was the one who translated Seth Lokamal Chandrai's dream to reality. On 6 July 1973, the hospital was inaugurated by the erstwhile dynamic Prime Minister of India, late Mrs. Indira Gandhi. Today, we serve over 50 specialties with over 300 beds. Jaslok Hospital has been synonymous for best-in-class medical services with state-of-the-art infrastructure, advanced technology that is manned by trained and dedicated staff, many of whom are the trainers in the country. I must mention that we have 6 centers of excellence, in which for 3 centers of excellence, we have female directors. Proud to mention that. Voice of Healthcare is a national entity, a not-for-profit healthcare industry platform, a society by constitution. VOH is a discerning and visionary think tank for healthcare sector in India. making healthcare a priority for all by continuously collaborating with diverse stakeholder groups and shaping innovative solutions through learned shared learnings. This year, this collaboration is with an intent to create awareness amongst the general public on government laws for assisted reproduction techniques, infertility treatments, recent advances, supporting an improvement of reproductive medicine, the ethical issues related to ART, general health concerns of women in life's different stages. So let's kickstart the event with a warm welcome address by Mr. Jitendra Haryan, CEO of Jaslok Hospital. Mr. Haryan is an entrepreneurial senior level executive with nearly 25 years of quantifiable achievements. He is a seasoned professional with strong strategic and analytical skills with a sound execution expertise. In his tenure at Jaslok Hospital, the hospital has seen phenomenal improvements in services, infrastructure, technologies, all to ensure empowering patient and enhancing patient experience. For the Jaslok family, he is the core of our energy. I welcome Mr. Jitendra Haryan to give the welcome address.
Thank you, Jyoti. I think today it's not about my introduction. I think it's about the women in general. So today, on the occasion of International Women's Day, I extend my heartfelt wishes to all the incredible women in this room and in the audience. We celebrate today your achievements, your strength, and the invaluable contributions you make in every sphere of life and your inspirations. On behalf of Jaslok Hospital and Research Center, I'm honored to welcome you all to this panel discussion in recognition of International Women's Day. As we celebrate achievements of women and girls globally, the WHO theme for this year, Invest in Women, Accelerate Progress, resonates deeply with us at Jaslok Hospital. This year marks a significant milestone for Jaslok Hospital, our 50th anniversary. Throughout these 5 decades, we have witnessed firsthand the immense contributions of women to the healthcare field, both as doctors and caregivers. Women contributors would be more than 50% in healthcare services in India. Their strength, resilience, and dedication have been instrumental in shaping the landscape of healthcare. And today, women's presence and contributions are indispensable across all fields, not just healthcare. On this occasion, I also want to acknowledge the unwavering dedication, passion, and commitment displayed by countless women who served the community selflessly during the pandemic. Their contributions played a vital role in supporting and caring for others in a time of great need. Today's panel discussion brings together distinguished speakers to engage in a meaningful conversation about investing in women's health and well being. This aligns perfectly with the WHO's theme, emphasizing the critical role women play in driving progress across all aspects of society. I would like to extend a warm welcome to our esteemed chief guest, Honorable Ms. Aditi Varda Tatkare, Minister for Women and Child Development, State of Maharashtra. Thank you, ma'am, for taking out time from your busy schedule. I also like to extend my warm welcome to our keynote speaker, Dr. Daksha Shah, Executive Health Officer, MCGM, and the moderators, Dr. Firuza Parekh, Director, Assisted Reproduction, Jaslok Fertility, and Dr. G. N. Mansukani, Director, Gynecology, and all our esteemed speakers. Your presence and insights will undoubtedly enrich our understanding of this crucial topic. I also want to acknowledge our esteemed collaborators, Voice of Healthcare, for partnering with us in organizing this event. We have Dr. Navin Nishchal, Chairman, VOH, with us today. Welcome, sir. Together, we aim to foster a platform for dialogue, collaboration, and action towards a future where women are empowered to reach their full potential. Without any further ado, I invite you all to engage in these interesting discussions and gain valuable insights from our esteemed speakers. Thank you. Jyoti, over to you, please.
Thank you, sir. Thank you for the warm welcome. Due to some technical issue, Honorable Cabinet Minister Ma'am is going to take another 5 minutes. There are some technical issues at her end, so let's wait for her. With pleasure, I introduce our next speaker, Dr. Navin Nishchal, Chairman, Voice of Healthcare. Dr. Navin Nishchal is a distinguished healthcare delivery expert from Harvard Business School and a seasonal serial entrepreneur. Renowned for his significant contributions, he has successfully established a chain of hospitals for Tier 2 cities of India and health tech startup on primary health. Dr. Nishchal currently serves as a chairman at Voice of Healthcare and the VOH Incubator, further exemplifying his commitment to advancing healthcare innovation. May I please welcome Dr. Naveen to take over?
Thank you very much, Jyoti. Thank you very much. Respected fellow speakers, Mr. Jitendra Haryan, Dr. Daksha, Honorable Minister, she's about to join us for this discussion. So first of all, I would like to wish all of you a very happy International Women's Day. And this is a great opportunity for me to be with my fellow speakers and with all our audience of Voice of Healthcare on this occasion. Today, I want to address a very crucial aspect of women's well-being, especially in a country like India, where women's health is often overlooked. I would like to shed light on a social issue, the tendency of women to prioritize others over their own health, enduring pain silently for the sake of their families. Cultural norms often discourage women from prioritizing their own well being, and this leads to underreporting of serious ailments. We as men sometimes overlook their concerns, resulting in delayed treatment. You will find these examples in your families as well. I remember my mother when she had chest pain, she told me only after a month. And when she had some, blood in sputum, she told me after a couple of months. Her usual response was that I do not want to disturb you, I do not want to bother you. On this International Women's Health Day, I urge every woman, whether you are a wife, mother, sister, to speak up for yourself. It's essential to raise your voice because nobody will listen until you speak loud. I encourage each one of you listening to who are listening to this podcast and this session to share this message with every woman you know. Today, I would like to touch upon lifestyle diseases and infertility in women. I think it's high time for all women to take charge of their health, considering the challenges that lie ahead. Our sedentary lifestyle has more profound impact on females, while lifestyle diseases like diabetes, hypertension, these diseases affect both genders. Issues like PCOS and fertility are increasingly common in females. At Voice of Healthcare, we are working towards accessibility, affordability, and quality of healthcare in India. Simultaneously, we are committed to uplift women's health, especially in urban slums and rural India. So let us pledge to be advocates for change. Let us stand together in support of women, breaking down the walls of silence and stigma. By doing so, we contribute not only to individual well being, but to the collective strength and resilience of our society. Thank you, and let us continue championing the cause of women's health on this International Women's Day and beyond. Thank you very much. Thanks.
Thank you, Dr. Naveen. It was really very nice and motivating. We are having our cabinet minister joining in soon, and I think she's in. So I take pleasure and great honor in welcoming Honorable Miss Aditi Varda Tatkare, the Honorable Minister for Women and Child Development for the state of Maharashtra. Ms. Tatkare ma'am has held several notable positions in her career. She served as the president of the Raigad Zilla Parishad from 2017 to 2019, demonstrating her leadership skills at the local level. On December 30th, 2019, she became Minister of State in the government of Maharashtra, holding key portfolios such as industry and mining, tourism, youth and sports, welfare, horticulture, development, information and public relations, law and judiciary, protocol department. The Ms. Tatkare's tenure as a minister has been marked by her active involvement in handling diverse departments, contributing to the governance of Maharashtra. In July 2023, Honorable Ms. Tatkare became the Minister for Women and Child Development Department for the state of Maharashtra. It's my honor to welcome you, ma'am. Thank you for being there with us. Over to you, ma'am. Ma'am, you're muted. Honorable Ms. Aditi Tatkare has requested Dr. Daksha to first do her talk. So let me have the honor of introducing Dr. Daksha. Dr. Daksha Shah has over 28 years of experience in MCGM. She acquired MBBS from Topiwala National Medical College, Mumbai, holds a diploma in public health, WHO fellow, and Fulbright scholar and Humphrey fellow in public health policy and non-communicable disease from Tulane University. She also holds international masters in health leadership from McGill University, Canada. As a Deputy Executive Health Officer, Epidemiology Cell, she worked closely with state and government of India teams to control and manage the COVID-19 pandemic in the city. She undertook several research projects such as serosurveillance, vaccine trial, use of artificial intelligence in COVID-19 care. Dr. Shah played a pivotal role in developing a comprehensive TB-free Mumbai plan, a roadmap for 5 years. I request Dr. Shah to deliver the keynote address on the ART Act and the government's integral role in encompassing the infertility concerns. Over to you, Dr. Daksha.
Thank you, Jyoti. I hope I'm audible to all. Is this on? I'm just checking.
Yes,
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 I'm
you are.
on.
You are.
Thank you. So, first of all, Honorable Minister Ms. Aditi Tatkare, Minister of Women and Child Development, Maharashtra State, Navin Nishtil Sir from VOH, Mr. Harian, CEO, Jaslok Hospital, all the distinguished and eminent panelists for today from Jaslok Hospital and Specialities, all my friends and colleagues who is there today on the panels, and all the viewers and participants. A very good afternoon to all of you. On this Women's Day, first of all, my greetings to all the beautiful women over there. And Nominista has already introduced the topic of today's Women's Day. So I think, first of all, I will thank Jaslok Hospital and VOH for inviting me as a keynote speaker in this important dialogue, which not only touches the topics of infertility, but it also covers a lot of issues of the women health, and especially a special care during the antenatal period, adolescence care, menopause, and so on. So I thought, as a keynote speaker, what should I touch upon? I thought that rather than talking about the health, which most of the panelists will cover, I'll talk a little bit about the regulations and the new acts which has come up, and especially the Surrogacy Act and the ART Act. So can I have the first slide, please? As we all know that infertility, the prevalence is rising world over. And as per the WHO estimates, 17.5% of the young adult populations experience infertility in their lifetime. Our own data from AIMS also says that around 10 to 15% of the couples have fertility issues. And if you see the NFHS, that is the national survey, the fertility between the survey 4 and 5 has gone down. So, of course, because of so many reasons, because of urbanization, because of stress levels, and because of, lifestyle changes, the age of marriage is, increasing. And of course, the choices of women more, focus on the career. And there are a lot of issues which is happening. And I'm sure that the topics will be dealt in detail by all the consultants and all the experts in this panel. So I'll be more focusing on the ART and the surrogacy. Can I have the next slide? Next. So we have a very next one. There is a long history of surrogacy and as well as ART and IVF, in the country. I think the first took place in 1978. And after that 8 years, I think in Mumbai, in KM Hospital, the first test tube baby was born. Now, India has become a popular destination for surrogacy tourism, I would say, because of the low cost and, easy availability of the surrogate mothers. And along with it came the commercialization. That is, the commercial surrogacy was also, now it is becoming common. And due to the lack of clear regulations and legislation, there was a sharp rise in the surrogacy uncontrolled in India. Now, I just want to, remind you of some movies. Even our Bollywood movies have touched upon this subject. One such, I think, movie I can recollect is Mimi. which I think came in 2021, where a young woman who is unmarried who chooses to become a surrogate mother for a American couple, and this couple in exchange of some cash, and then she conceives through IVF, and then later on the couple finds out that there is some Down syndrome, the child is suffering, and they refuse to accept the child, and they ask the woman to kind of abort the child, and the girl she refuses, and then she carries on with the pregnancy, and the child which was born is healthy, and after that the couple returns to reclaim the child. So then she refuses. So there was a lot of drama, and then ultimately the woman gets the child. So this kind of the regulation is not there, so there are confusions what is to be done in such situations and all. And also we have certain other movies like Good News, then Chori Chori Chupke Chupke, and I think Vicky Donor was a very big hit, where it actually says about the sperm donation by a man in exchange of some financial gains. So I think Bollywood has dealt with this topics very well. So going further in my talk, I would say that many low-cost fertility clinics and exploitation of underprivileged women and rise in malpractices has happened, and there are cases of child abandonment because of if there is confusion who will take the care of child. Then of course these cases are rising. There are some records also which I'll not go into details, but times and again we read such newses. And then there is this real urgent need to safeguard the interest and of the infertile couple and also the surrogate mothers, and that is why this legal and ethical framework has come up. Can I have the next slide? So we already have this PCPND Act, which many of you must be knowing, since there are non-medicals also in this seminar, that PCPND Act actually restrict the sex determination, and there is a stringent act, there is a stringent punishment, and we as a local authority, we implement this act, and we have the mechanism to cross-check the centers where the sonography is happening and so many other radiological procedures are happening, and we have a systematic meetings and identifying these centers. Now there is a part of this PCPND Act which covers the regulations, genetic counseling, genetic testing, and IVF procedures, but not as a whole. So there was a need of this act. So 2021, this ART Act as well as the Surrogacy Act came, and then there is a national board and there is a state board, and there is a local health authority which then implements the act. Now, this is to ensure the regulation and supervision of all the ART banks and ART clinics, prevention of misuse and safe ethical practices for the services, and also punishment for those who attempt to control the sex as well as the cell of the embryos or the gamete. And these all protocols are standardized, and registration and renewal of these clinics has been also defined in the Act. And there is an establishment of a national registry. There is a national portal on which all these ART clinics, surrogacy clinic has to be registered. Can I have the next slide, please? Next. So this Surrogacy Act in particular, these clinics, unless registers, we cannot have now surrogacy procedures. Nobody can conduct surrogacy procedures if that clinic is not registered with the government or the local health authority. Then there is prohibition of commercial surrogacy, as I said earlier. Also, there are no advertisement or propagation of the surrogate mother, or a commercial surrogacy is not allowed. Then eligibility criteria for the couple and the surrogate mother is also defined in this Surrogacy Act, and the protection of the rights of the surrogate mother and surrogate child, both it's all being covered into the Surrogacy Act. Next. So going further, in Mumbai, we have around 27 surrogacy clinics which we have already registered, through the public health department, and 190 ART centers they've applied, and we'll be soon registering them after the visits and all. These are some of the charges, the registration fees for the interest of the the gynecologists who are there. And there is this national ART portal and the surrogacy portal on which these all application goes. Next. So I'm going to explain a little bit about the process of the registration of the surrogacy clinic. So application goes to the national board. There are payment of fees. There is appropriate authority of MOH of that local ward. So Mumbai is divided into 24 wards, and similarly, other parts of the country in the districts, there is a district health officers who actually goes and inspect regarding the clinic, equipments, manpower, infrastructure, qualification, etc. And then the recommendation comes to the district medical board. So for the purpose of monitoring, we have kept this district medical board in Mumbai because we have 24. We have a very huge workload. So this comes to the medical board, and this appropriate authority in Mumbai is the executive health officer, that is myself and my colleagues. As well as we have a special officer. She's today joining me, Dr. Vaishali, who looks after this day-to-day affairs of registering and these other processes. And we have the MOH of Concern Board, who is the appropriate authority. And this approval is done by the MOH office, and the state authority confirm this approval, and then the surrogacy clinic gets registered. Now, what is the process for the surrogacy for the couple or for the mother? So that I'll little bit talk on detail in the next slide. Next. Can I? So there is kind of a elaborate process which I think any intending couple or the mother has to understand. So there is this eligibility certificate which has to be produced, or which has to be obtained by the eligible the intending couple from the local health authority. These are the eligibility criteria which I have shown over here, that the person or the couple has to be Indian or an overseas citizens of India, ever married, the age has been defined. Also now the woman who is single or divorced widow has been also been allowed. Current residence has to be in the local, that is in Mumbai, and the medical indication of surrogacy is also very important. This medical indication of surrogacy is been now given as a recommendation letter from the surrogacy clinic or the gynecologist of the choice of the intending couple. So they have to have this recommendation letter from the surrogacy clinic regarding the medical indication. And then they apply to the district medical board. Now, district medical board again consists of the head of the Department of Gynecology, pediatrician in our board, myself and my joint executive health officer and special officer of family welfare. So we have this district medical board, which is again approved by the state health authorities. And then these all papers have been verified, and then the medical indication certificate is given by this board. Then again the eligibility criteria for surrogate mother is checked. So there is a certificate for the surrogate mother. Now mother has to be an Indian, she has to be married, at least one living biological child, and medical fitness is also important. So any registered practitioners can take the medical fitness, and with this all certificates, the MOH, the local health authority, gives the eligibility certificate to the surrogate mother. And then also there is an insurance for 36 months has to be insured by the intending couple for the surrogate mother. And then with all this, there is an essentiality certificate which has been issued by the MOH, that is with eligibility, all these certificates. And then the court has to get an order, that a couple has to get an order from the court of the parentage. Now this is basically defining all the rights and legalities of the later on what happens to the child and all. Can I have the next slide? So these are in short some of the certificates which is required. Can I have the slide, please? Next slide. Jyoti? So as I said, that we require all these certificates before a surrogacy is decided. The intending couple has to know the process. The surrogacy clinic and the physician who is actually going to handle the surrogacy has to know what are these certificates has to be required, so they can counsel the couple. They can actually inform the couple that how to go about. So most of the couples, they apply to the local health authority and to the surrogacy clinic, and those papers then come to the medical board. So we actually, the district medical board provides the medical indication certificate, and then there is this insurance certificate and essentiality certificate, and then the order of parentage. So these are the certificates, and with this now the surrogacy is allowed in the choice which the intending couple has within the Mumbai. Now over the period in last 2 to 3 years, because there are certain amendments now which has come, because there were still there are certain gray areas, and it will keep changing over the years as we go through this, because this is a new act and this is a new process. So even we learns a lot of things. There are a lot of ifs and buts comes up. So we need to ask the state authority or sometimes the central government also what to do in certain cases. So over the period, as I said, 2 to 3 years, there are certain amendments which I'll just show you. Next slide. This is just the ART clinic registration, which is usually done by the state authority. So once the ART clinic has been visited by the MOH after the inspections, the recommendation goes to the state health authority. So there is this team which is right now under process, where we have given all the details about the ART clinic in Mumbai, and they are visiting, and they are now recommending, and they are approving these ART centers and these ART clinics that is been now registered through the state health authorities. Next. So this I just wanted to highlight. So now the amendments. Now initially it was allowed that the place of residence the intending couple has to apply, but now as per the amendment of January 23, place of residence due to employment is also allowed, and also surrogacy regulations now don't allow that change of application is only through the state and the national authorities. The one important change which now has come on the 21st of February 24 is that one donor gamete is to be there, or I mean, one gamete has to be there by either of the couple, intending couple, and only one gamete is allowed from the other party. So in this one donor gamete, if then the district medical board certifies, then either of the intending couple suffers from other medical conditions, then it will be necessary that the child who is to be born must have at least one gamete from the intending couple. So this is an amendment which has come, and I'm sure that as and when the act matures, there will be many more amendments, and it will address some of the concerns of the doctors and the parents also. So with this, I would just summarize that next. That appropriate and effective use of these both act, that is ART and Surrogacy Act, it will help us to curb the malpractice and exploitation of the vulnerable woman, and always as a surrogate mother as well as the couple. And we have to ensure the proper implementation and supervision of these acts, and for this we all need to work together. And I really feel that this was a new information which I needed to give to the participants. And along with this, I would just like to add two or three more initiatives from the BMC. We are also providing counseling services to the women who are experiencing or who are the survivors of the sexual violence or a domestic violence. We are running Dilasa centers through our NUHM program, and in our 12 hospitals we are having these Dilasa centers. So any woman who needs help, who needs counseling, a legal support, or a police complaints to be lodged, they can approach our hospitals. These centers are there in our hospitals, and we have counselors, we have nurses who can help out the woman, and we are having systematic data collections of these happening, and we're expanding this program to reach out to more women in the community to help and support more women survivors of the domestic and the sexual violence. So with this, I conclude my talk, and I thank all of you, for a wonderful participants, and I hope that my information will help those couples who are planning for any surrogacy or ART, and I'm sure the talk will be more elaborated during the further panels. And I thank again the Jaslok Hospital as well as the BOH for inviting us for this panel. So thank you, and wishes once again to all of you, and also Madam, for joining us today. Thank you.
Thank you, Dr. Daksha. That was really, really educative for all of us, especially lay people like us have really got an idea exactly how the act works. Thank you so much for being there with us today. You really enlightened all of us.
Thank you.
We'll be shortly having our next distinguished speaker, the chief guest, Honorable Minister Aditi Varde Tatkare, the Cabinet Minister for Women and Child Development for the state of Maharashtra. Honorable Minister will be connecting in a minute.
So, while Honorable Minister joins this conversation, I wanted to interact with the fellow speakers. I have a couple of questions, and I wanted to, because everybody is here on the panel, I wanted to have this liberty of speaking to fellow speakers. So, Dr. Daksha, this was a wonderful presentation, and a lot of people, they don't know about this new bill, and there is so much confusion amongst general public, especially about surrogacy. And you rightly mentioned all those Bollywood movies which have some where all these cases have happened. So earlier it was when I look back, earlier surrogacy was very easy before this bill, and people from abroad or wherever they wanted to have babies, and they used to get mothers to carry their children very easily in India. So I a friend of mine, I mean, it's a question. A friend of mine who is based out of the US, and she's an Indian. I think, ma'am has joined us. Honorable Minister has joined us.
Yeah, hi.
Hi, Aditi ma'am. A warm welcome to you.
Thank you. Thank you.
Hello,
So,
madam.
ma'am,
Yes. Sorry, I've been traveling, uh, so I haven't been able to participate in the program, like in the entire program.
No problem, ma'am.
over
No
to you,
problem.
ma'am.
Yes. Uh, so, firstly, I would like to thank Jaslok. Um, and I'll take this opportunity to congratulate them as well that they are entering their 50th year of service. Uh, also, it's Women's Day, so I wish all the women um, on the panel as well as across the state a very happy Women's Day. I think this is one of the most important and prominent day when it comes to women working in different fields, and the housewives as well. As women, it's always a proud moment and day for us to get a special day to celebrate our womanhood. I would like to thank the organizers for organizing this discussion session on infertility and other health issues regarding women. As government, today is an extremely proud moment and day for us as well, as we have come up with our fourth women policy that we've announced on the occasion of Women's Day. This is our fourth women policy of the state. The first, which was launched in 1994, and the second one in 2003 2004. The third one was in 2014, and now we've come up with the fourth women policy in 2024. So it's an extremely proud moment for us. Um, what we've emphasized um, in the women policy is the women health, giving them an equal opportunity, treating gender equality. Also, uh, we are emphasizing on participation of women in environment related activities, women security, um, women education. So these are certain things that through policy we intend to emphasize on. Women health obviously is one of the most important things. From last many years, government has been trying and implementing various schemes and policies related to women health. Uh, we need to really emphasize more on mental and physical health of women. So that's what we have been trying to achieve from last 5 years as well. In the last 5 years, government of Maharashtra has tried to emphasize more and more on women health and child health as well. Uh, from here on as well, we intend to work on issues like postpartum depression, on issues like anemia, and issues that women and emphasizing and promoting institutional deliveries in rural part of the state. So these are certain issues that we intend to focus on in the coming year as well. Affordable medical treatment, free medical treatment are something that we should, as a government and organizations, that we should togetherly work on. I remember I would really like to mention that Jaslok had come ahead when we were just sometime some months back when we had a huge calamity in Raigad. So Jaslok and government had come together, and the Women and Child Development Department had come together for in organizing the medical health checkups of women and the kids who had lost both their parents, uh, to provide medical help to them. And Jaslok came ahead and adopted these kids, and ensured us that they would provide them with good medical health facilities till they turn 21, till they turn adults. So activities like these, along with the government and organizations, should be focused more on. When it comes to infertility care, promoting gender equality, educating women more and more about their rights, more and more about their physical and mental health. I think such activities should be taken ahead and be focused on. So I hope all of us together uh, try and make this society a better place for women to live in. Obviously, we are still in the era where we have to focus and give special preferences and have to make certain advances to for women reservation, or for giving them special, or making some efforts to give them to be treated equally in society. So certain things like certain activities like healthcare, nutrition, education, protection, awareness, which can be done togetherly, will surely change the situation. I hope there is a day when throughout the year, 365 days, we are able to celebrate womanhood in with the same zest that we celebrated on Women's Day. So I thank Jaslok once again for organizing this activity. They have been organizing such sessions uh, on every Women Day and other days as well. So togetherly we can. I mean, just yesterday we had a program of women and child development where we had self-help groups and them advocating about and promoting healthcare of women. So what I feel as government, what we can do is we can invest more and more in women related activities, and that's what we as government and department tend to do. I hope organizations as Jaslok and others as well come along so that we can take this women empowerment activity ahead. And health, I think, should be the topmost priority, as we all say that health is wealth. So women usually ignore their health because with their day-to-day responsibilities of taking care of the family, of taking care of the home. It's often found that women, especially in rural areas, ignore health, and that really causes harm to their entire lifestyle. So I personally feel that we should more and more emphasize on promoting health programs, activities in the rural and in the small urban areas of our state. I once again thank all the panelists. I hope someday maybe we organize a program in Jaslok and I've been able to physically be there and participate in such discussions, panel discussions and activities. Thank you once again. I thank organizers again and I wish them all a very happy Women's Day.
So thank you, madam, for taking out time and attending this event and sharing your thoughts on women development and women empowerment in the state of Maharashtra. You yourself are a source of inspiration for many women in all across, not only Maharashtra, I think, but across the country. So thank you once again for your time and your
Thank
thoughts.
you.
Sharing
Thank
your
you so
thoughts.
much.
Thank you. Thank you, ma'am.
Thank you, ma'am. It was an honor and privilege to have you on this event. So moving ahead to our panel one, inclusion, inspiration, and defying infertility. Inclusion, inspiration, and defying infertility are interconnected themes that touch upon different aspects of infertility under the guidance of our experts. We will be addressing infertility, fostering a culture of inclusion, drawing inspiration from shared stories of resilience, and recognizing diverse paths to parenthood contribute to a more supportive and understanding community. Additionally, continued advocacy for research education and accessible fertility treatments can contribute to breaking down barriers and promoting inclusivity in the context of infertility. I'm honored to introduce the moderator for this panel, Dr. Firoza Parekh, Director Assisted Reproduction, Jaslok Fertility International Fertility Center. Dr. Firoza Parekh comes with a rich experience of over 41 years. After completing her MD DNB at Mumbai, with several gold medals and first ranks, she pursued her training in IVF and reproductive endocrinology at Yale University School of Medicine in USA under the mentorship of Dr. Alan DeCherney. In 1989, in India, she set up the first IVF center at Jaslok Hospital. The center quickly gained a reputation of an outstanding international center, receiving patients from all over the world. She started the genetics laboratory as a part of the IVF Center in 1999, which was equipped with karyotyping and fluorescence in situ hybridization, fish techniques on a variety of tissues. Her work has helped countless couples overcome fertility issues and build their families. She is widely respected for her knowledge and expertise and continues to be the leading voice in the world of reproductive medicine. Recently, her team delivered the 20,000th baby, which is the highest number in India in private sector hospital. With a distinguished career, she is a recipient of Icon in IVF in India 2019 and 2022 by Economic Times Healthcare Awards. She was awarded PhD for genetic testing on the arrested and slowly cleaving embryos. She is a guide for PhD and MSc by Research for Mumbai University. She is also the editor-in-chief of the scientific journals Fertility and Sterility, Indian edition, and a member of editorial board of the scientific journals Fertility and Sterility USA and Fertility and Sterility Science USA again. The esteemed panelists are stalwarts in their field of expertise, along with Dr. Firoza Parekh today. That is Dr. Sujata Savkar, Dr. Sapna Agarwal, Dr. Madhvi Panpalia, Dr. Mamta Katakdhond, Dr. Jyotsna Palgamkar, and Dr. Swarna Gupta. May I have the honor to welcome Dr. Firoza Parekh and hand over the panel to her.
Good afternoon, Jyoti. Good afternoon, my friends. It is indeed an honor and privilege to represent the women, the Indian women, and the global women at large through this panel of mine, which has 6 brilliant, compassionate, kind, and astute women giving utmost care to the infertile couple. At this outset, I would like to thank our Honorable Minister, Ms. Aditi Tatkare, Dr. Daksha Shah, who has always been the guiding light for us whenever we have had difficulties at the MOH level. She's an expert and sorts it out for us. Dr. Naveen Nishal, who has been the main propagator for this panel, Mr. Jitendra Haryan, our CEO, and the countless people who support us in this endeavor to serve the women. You've already been introduced to our panel, so I will go further ahead without any ado. The woman at large forms the epicenter, the fabric of society. And therefore, she's the daughter, she's the mother, she's the mother-in-law, she's the daughter-in-law, she's the friend, she's the soulmate of a husband. But in that, she loses herself sometimes and forgets to take care of herself. Infertility is not just a disease, it is a stigma which we all have to overcome. We have to offer an infertile woman the equanimity, the kindness, the concern, and the equality that she deserves. In today's panel, we will be talking about what we can do to elevate the suffering in the mind and in the body of such women. The WHO had a definition for infertility which said that a couple has to be trying for at least 2 years before we can label them infertile. Today, just last year, or rather this year, this definition has changed. It no longer looks at the age of the woman. It says, if a couple has been trying for having a baby regularly with unprotected intercourse for just 1 year, then the alarm bell should go off and they should quickly visit the infertility specialist. Having covered this definition, we know today that a few years ago, it was that 8 to 12% of couples were infertile. Today, it is 1 in 6 may be infertile. And why is it so? I would say there are 2 kinds of infertility. The involuntary infertility, which we will address, and the voluntary infertility. Today, couples are delaying childbearing, particularly women. They're climbing up the ladder of their social well-being, but falling down the cliff of their reproductive health span. And here we have to emphasize that although women are most fertile between the ages of 24 and 34, they are also climbing up the ladder of success at this very particular age. So all you young and beautiful women, I urge you, do not neglect your fertile status. Be a little intuitive about your body, respect your body, and also claim your fertility status. With that, I open up this panel with my wonderful team, many of whom have been with us, with me and the hospital for more than 30 years. We also have some youngsters who have been here with us for about 4 years. Let us now open up the panel. I'm first going to invite Dr. Jyotsna Palgaonkar. Jyotsna, welcome to this panel. And I will start by asking you some very basic questions which you can talk to the viewers and the listeners about some of the common causes for infertility. Not only that, Jyotsna, I want you to go ahead and explain what work we have done in this field. Thank you.
Thank you, ma'am. Good evening, all. Happy Women's Day to all. Now I'll be enlightening upon the topics like causes for infertility. The causes for infertility can be divided into 4 parts. First is male factor, which attributes to around 30%, female factor, which attributes to around 30%. Both common male and female factor together combination attributes to 30%. Unexplained infertility attributes to 10%. What are the causes for male infertility? Now, the condition that affects sperm production, spermatogenesis, and also which affects sperm quality. Most common like undescended testes, genetic causes like Y microdeletion, hormonal problem. Recently, Indian population are prone to have diabetes, So that is one of the factor. Hypothyroidism, infection like chlamydia, gonorrhea, mumps, which can affect sperm production. Enlarged scrotal vessels, varicocele, which affect the sperm production. Again, environmental factor, pollutions, chemical, radiation can also affect sperm production. Now, moving on to the other condition where the sperm cannot reach the female reproductive tract, like genetic problem like absence of vas difference, any injury during the surgery, genetic condition like cystic fibrosis, which affects the sperm reaching the female reproductive tract. Other sexual problem like premature ejaculation, erectile dysfunction, which can all relate because of the stress due to recent lifestyle. Now moving on to female infertility. Female infertility we can be dividing as ovarian factor, which can be due to polycystic ovarian disease leading to anovulation, ovarian insufficiency, as we have done a paper on AMH which shows Indian females less than 30 years, 25% have around less than 2 nanogram of AMH, means the ovarian reserve below the age of 30, 1/4 of the population have low AMH. Again, in the age of 30 to 34, around 50% of women have less than 2 AMH, 50% of the females. Moving on to 35 to 39 year of age, around almost 70% have AMH less than 2, which is very significant because during that time people have completed their career and they look for fertility treatment. Now moving on, other factors like Turner syndrome, which is genetic condition, radiation hazard, exposure to radiation, chemicals, endocrine disruptors, all can affect ovulation. Again, like hormonal imbalance, hypothyroidism, then hyperprolactinemia, all which can affect the menstrual cycle, indirectly can affect the fertility issues. Now moving on to other barrier factor like having endometrial polyp, in the uterine condition, fibroid, which can cause physical barrier for the sperm in meeting the eggs. Other factor like adenomyosis, which can affect the uterine contractility, endometriosis, which is recently seen due to delayed childbirth, which can affect ovaries, which can affect the fallopian tube. Again, in India, tuberculosis, genital tuberculosis, the prevalence is 9%, which can again affect the fallopian tube, which can affect the endometrial lining, thereby affecting implantation, affecting the pregnancy in India. Other causes like pelvic inflammatory diseases, infection, adhesions due to previous surgeries, exposure to chemotherapy, radiotherapy, which are recently seen, increasing cervical cancer, ovarian cancer. So all these factors can affect female infertility. Now moving to the risk factors, as madam has already described, age, because women are more career oriented now. So the age is most important factor. Now, if the couple is attempting fertility, if the female age is less than 30 and male age is less than 35, the conception rate is seen to be higher. This is one of the most important risk factor. Again, if the weight is more important, if the couple, both male and female, have maintained their ideal weight, they are trying exercise, then the chances of fertility is much better. Again, uses of the chemicals like heavy makeups and all this thing, having high leads and mercury, which can affect the fertility, which can cause hormonal imbalance, exposure to chemical radiation, occupational hazards where they are more exposed to radiation can affect fertility. Apart from this, nowadays everybody is having stress in their life. So couple who are more under stress like depression, anxiety, they have negative impact on the fertility because they are more involved in the negative lifestyle, which can again affect the fertility. So the couple who are trying for fertility should be looking for some stress relief, relax, some meditation method to reduce their stress. Other factor which I can relate to is uses of tight undergarments for males, which can again decreases the sperm production. Use of hot water bath can affect the sperm production. Use of recreational medicine, drugs, smoking, alcohol, all can affect the fertility by decreasing the sperm production and affecting the ovarian reserve. So, ma'am, I would like to summarize all these factors most commonly related to infertility.
So, Dr. Jyotsna very succinctly has, in a nutshell, explained to us what are the reasons for infertility and what are the common reasons. And I think we need the doctors to be very astute to take a good history to find out what is the reason for the infertility. Swarna, let's move on to you. Dr. Swarna, I want to ask you some very basic questions. We know that there are a whole lot of hormones that take a part in the reproductive cycle, starting right from menarche all the way to premenopause and menopause. In a nutshell, can you explain to us what these hormones are, both in the male and the female, and how they affect the reproductive cycle?
Sure, ma'am. Thank you so much for the opportunity. First of all, very happy Women's Day to all the viewers and the listeners. Now, as Madam said, the little bit knowledge about how the hormones play an important role in female and the male. Usually, when we talk about the hormone, there are lots of hormones which we can test and do. But I'm going to talk about the 5 key hormones which are really very essential in the female reproductive part. First hormone that we are going to talk about is the FSH, that is follicular stimulating hormone. It helps in the development or the growth of the egg. This hormone can be detected on by doing a blood test on the day 3 of your menstrual cycle. Supposingly, if this hormone has a very low value or a high value, it can trigger your brain or can give you a signal that there is something not right with your fertility issue. You need to see your IVF specialist and get your checkup done for that. The second hormone which I'm going to talk about is the LH, luteinizing hormone. You have often seen people over the counter doing something called as a ovulation, using ovulation kit to detect the LH surge. How this LH surge works? It works because of the LH hormone. Okay, when we give them body, when the LH surge happens, it eggs the make mature that is capable of fertilizing the egg. When we do the home test or the ovulation test, sometimes we can detect it, but obviously there is pros and cons to everything. The third hormone, which is very often, and as Dr. Jyotsna said, it's a very important risk factor, is the risk. Is the stress. Stress hormone can increase the level of something called as a prolactin hormone. When the prolactin hormone increases, women often miss their period. They say the ovulation has delayed because of the high prolactin level and they don't get their menses. Often we see women who are undergoing some stress or the exam, they say, doctor, I have missed my period. Why so? It is because you are under stress, your hormone levels have been abnormal and your ovulation get delayed. The fourth hormone, which is really very important and I'm going to talk about in detail, is the thyroid hormone and the antibodies related to it. Often hypothyroidism and the hyperthyroidism both can impair the fertility and the hormonal imbalance in the female body. They decreases the level of the other hormones like FSH and LH and may interfere with the fertilization rate. And mostly people don't talk much about the thyroid antibodies, which at our center we make sure we do it, we treat it so that it should not interfere with our ovarian stimulation, or when the patient is undergoing embryo transfer, it should not interfere with the pregnancy and patient should not have a miscarriage. The other hormone which is very important is the AMH, that is anti-Mullerian hormone. This is the hormone which reflects the continuous non-cyclical growth of the small follicle. This is the one test I would like to tell every physician, whoever sees a woman, please do this test so that any women who can make a confident decision and an informed decision about whether at what time she want to plan her parenthood and at what time she want to plan her career. It gives them a power that she can freeze her eggs, she can do the embryo freezing, and she can climb the ladder, success ladder of her career, and also she can have baby anytime whenever she want. Whereas these 5 hormones are really very important from the female point of view. Now, as we talk about the male reproductive hormones, The three hormones which are very necessary from the male point of view is similarly FSH, LH, and the testosterone. Testosterone is the most common androgen, which we all know and we talk about. It can, if the testosterone level is really low in the male, it may interfere with their libido. And the people often comes in OPD, doctor, I don't feel like that having a this relations. So, and similarly, when with something like this come up in the OPD, you need to assess the situation. You need to ask them to do the hormonal profile and go through it.
Thank you, Swarna. You have very nicely enumerated all the points that are required for having a good reproductive cycle. You have touched upon the hormones, their function, and their dysfunction. Let's now move on to a very interesting chapter in this panel, and that is the myths that exist when treating couples. You know, we've so many times we come across couples who come and tell us, or particularly the mother-in-law, shall I make sure that there is no food that is spicy for her? Shall I make sure that she's on bed rest after IVF? There are so many myths and so many misunderstandings. Dr. Mamta, can you enumerate some of these interesting myths and misunderstandings about IVF and infertility?
Sure, Dr. Parekh. In fact, a happy Women's Day to everybody. And I think this is the perfect opportunity to enlighten all the women around here and also to clear the clouds that are around infertility. So to begin with, we have many myths that come up. In fact, the most common that women think is infertility is only a woman's issue. So no, it's not only a woman's issue. In fact, there is a global study done which says that 35% of cases of infertility are also contributed by males. So definitely this myth is out. Then there is another myth which says that infertility is always treatable. Yes, as my colleague Dr. Jaslok has discussed about the different causes of infertility, yes, to some extent there are some cases which can be treated, but something like low ovarian reserve or basically azoospermia or something, that definitely needs assistance with IVF or any assisted reproductive techniques. The third myth that we commonly see is only women with infertility, in fact, even only women's infertility is affected by age, which again is not true. So let me explain you that as a woman ages, the peak reproductive period is between 25 to 35, and basically after 35, the fertility of a woman gradually declines, and after 40, there is a sharp steep. Now, what happens in males? In males, what happens? Of course, the peak reproductive period in the males is also between 25 to 35. And as the aging happens in male, the quality of the sperm also gradually decreases. And say by 40, there is a gradual increase in the DNA fragmentation. And we also see cases of sperms having genetic problems. Now, the third myth that we have seen, of course, I will be enlightening only a few myths, but the third that I go to is many women think that I have got a baby, so I cannot be treated with, I don't have infertility, which again is not correct to some extent, because a woman who has born a child can suffer from secondary infertility. Again, as my colleague Dr. Jaslok has already enlightened the causes, it could be one of them. So if any woman thinks that way, please visit a fertility consultant and we are happy to help you. Then the most common thing that now we see is lifestyle. People believe that lifestyle does not affect infertility. In fact, with the changing trends and the millennials that are coming and the Gen Z that I would say, more exposure to mobiles, gadgets definitely is a negative effect on infertility. The less of sleep, then working hours are, in fact, now the culture is of working, doing the abroad timings and all that. So they have erratic sleeping hours, then diet, more of junk food. They all have a negative impact on infertility. So for us to think that no, lifestyle doesn't affect infertility is not correct. Then there are also men who think that, okay, I can ejaculate, so I cannot be infertile. No, that's not true. Even if a man ejaculates, there may be some parameters in the semen which are very important and which have to be within the normal range. That is the sperm count, the morphology, the motility, they all play a very important role. And lastly, if a woman feels that no, if I have regular periods, I cannot be infertile. That again is a big myth. Yes, regular periods do signify that yes, you're ovulating regularly, but that does not rule out that you cannot have an infertility issue, because there could be tubal factors, there could be an ovarian issue which need to be addressed. Due to lack of time, have just enumerated few of the myths and conceptions. And if you have any more doubts and queries, we all are happy to help you. You can contact us at our email ID ivfjaslok@gmail.com or at the Jaslok hotline numbers. Thank you. Thank you, Madam.
Thank you, Mamta. So I would like to add on some interesting facts about some misconceptions. Yes, a woman's fertility practically stops by the time she's 40, and men are very lucky because Charlie Chaplin had a baby when he was 80. But there is a caveat, and the caveat is, as a man becomes older, the sperm tend to show more chromosomal abnormalities. So it is a well-established fact that men who have children at a later age, there is a higher chance of miscarriages and a slightly increased chance of some abnormalities and maybe even chromosomal abnormalities. So there is a time which is very important in one's life to have children. Men, yes, you can be virile till 80, but enjoy your fatherhood when you are 30 and 40. That is my message to you. Dr. Sapna, you are a very senior consultant with us, and you have seen hundreds and thousands of couples having different issues with fertility, but also there are couples who can get pregnant, they do get pregnant, but they have miscarriages. And miscarriages also become like a very big issue with fertility. Can you give us a little idea about why women have repeated miscarriages and what are the solutions for this?
Yeah, thank you, Dr. Parekh, and good afternoon, everybody. Before I talk for next couple of minutes, I want to say whatever the test and treatment option that I'm going to talk are available with us at Jaslok Fertility Center. These are some advanced treatment options that we have, we have been practicing, and we are very happy to say that we have been able to help many couples with many genetic and chromosomal problems leading to repeated miscarriages. Recurrent pregnancy loss, as we say, 2 or more miscarriages can cause significant emotional and social distress to a couple who's trying to get pregnant. And causes of repeated miscarriage can be multiple, which could be hormonal imbalance, autoimmunity, infections, environmental factors, toxins, congenital or structural abnormalities of the uterus, and then some systemic disease like diabetes. Importantly, HLA sharing is one of the causes that we do see in our practice often, and genetic causes. And I'm going to discuss here in detail about the genetic causes of recurrent pregnancy losses and how, as a fertility specialist, we can help these couples to achieve a normal and healthy pregnancy and baby. Fetal chromosomal abnormalities are one of the most common cause of early miscarriages. And fetal chromosomal abnormalities can be of 2 types. One is in the abnormalities in the number of chromosomes, what we call aneuploidies, and second is the structural rearrangement between the chromosome, leading to, say, translocation, inversion in the chromosome, which we see balance translocation, reciprocal, and Robertsonian translocation. And when coming to the aneuploidies, we have this happens actually randomly. And risk of this aneuploidy increases as the maternal age increases. And as we say, even the paternal age can lead to the abnormal embryos and leading to the recurrent pregnancy losses. And the most common number abnormality that we see is called trisomy 16, which we see very often. Others include trisomy 21, which is Down syndrome, trisomy 18, which is Edwards syndrome, and trisomy 13, which is Patau syndrome. These are the common aneuploidies that we see in the women having the recurrent pregnancy losses. And second type of chromosomal abnormality that we see are the structural rearrangements, in which there is the rearrangement of chromosomal material between 2 chromosomes, leading and couple having this kind of balanced translocation are at high risk for having recurrent pregnancy losses, because the fetus can have unbalanced translocation, in which during the process of shifting of the material, there is some material is lost or gained. So this can lead to unbalanced translocation in the baby, which can lead to recurrent pregnancy loss. This is one very important cause of recurrent pregnancy losses. So what we can do to help these couples, pre-implantation genetic testing is a great tool that we have to help these couples to have select the embryo without this abnormality and give them a fair chance to have a normal and healthy baby. And we have PGT-A, which is for testing of the aneuploidies. We have PGT-SR, which is for the structural abnormalities. In PGT, what we do in PGT, we have to create embryos using the IVF-ICSI technique. Once the embryos are formed and they reach day 5, that's the blastocyst stage, the embryos are biopsied, in which the few cells are removed from the outer layer, which is the trophectoderm cells are removed. Might be are not touching the cells which are going to form the baby. This is one worry people mostly have, that if we do the biopsy, are we going to affect the damage the embryo, which is not the case. And we have been doing this PGT for more than 20 years now, and we have a great team and expertise to do this PGT. So, and once the biopsy is done, embryos are frozen and these cells are sent for genetic testing to a genetic lab. And once we have the report, we know which embryos to be used, and we can only use the embryos which are normal. Then there are some couples who are the carriers for various known monogenic disorders like thalassemia, which is commonly we see in our practice, thalassemia, muscular dystrophies, retinitis pigmentosa, and even women who are having the breast cancer gene like BRCA1 gene, which can put a woman at a high risk for developing breast cancer. So these people can be, or these couple can be offered what is called PGT-M, in which we can actually test for these genes and eliminate the embryos which are carrying this defective gene and use only the genes which are embryos which are completely normal. These women, this couple need what is called pre-PGT workup, in which we need to first do the karyotyping to understand the chromosomal status of the patient, and also we need to identify the gene, in which particular gene, and develop a full protocol how to test this gene. And once we are ready with this, the embryos are tested and we can really eliminate the defective embryos carrying the defective gene and use only the embryos which are completely normal. And I am proud to say that in our setup, we have been able to help so many couples who are having this kind of problems like Robertsonian syndrome, and even women with breast cancer. We have tested the embryo and we are able to give the couple the baby which are not having the breast cancer gene, which will, this kind of testing not only helps this particular baby that we are going to get, also it eliminates, reduces the risk for the future generation to not have that gene carrying forward. So this is something that we are doing here at our center, and we are really happy to offer these services to everybody. And another thing I want to talk here is about male infertility. Here also we have some genetic causes which we can test and help couples with. So one, like as my colleague Dr. Josna mentioned in the causes for infertility, one is the Y chromosome microdeletion, in which there's some part of the Y chromosome is kind of missing. Because of that, there is a failure of spermatogenesis and the low sperm count. This test we offer at our genetic setup. Then another important thing is cystic fibrosis. There is cystic fibrosis is a condition which is characterized by tendency to have excessive scarring, and in this case we can check the men who have the azoospermia or very low sperm count. Cystic fibrosis gene mutation can be tested, and when we can and these papers generally present themselves with the obstructive azoospermia because of the congenital absence of bilateral vas difference. So they have people, if we can do this, then if we know that this particular problem, we can eliminate the problem in the baby, and this can be helped by using the ICSI, and we can do the TISA or PISA. We can extract the sperm from the epididymis or the testes. So these are the techniques that we have, and we've been using it here.
Thank you, Sapna. Just to enlighten the audience, ours was the first center in India that set up the PGT facilities. It was way back in 2000. And today we have given hope to couples where there is a history of Duchenne's muscular dystrophy, Huntington's chorea, thalassemia major, neurofibromatosis, many metabolic disorders, couples where there is a very strong history of breast cancer in the family, sickle cell anemia. So I urge fertile couples who are facing problems with repeated miscarriages or who have affected children, do visit us. We would be able to give you many solutions in genetics to have healthy babies. And I'm proud of our team in genetics, Dr. Arundhati Atelier and Dr. Prochi Mandal, who are both not here, but who are the main pioneers and carry the flag of PGT very high for Jaslok Hospital. Thank you. I now call upon Dr. Sujata Saukar, who is the senior most member of our team, been with us for years and years. Sujata has got special training in tubal factor infertility. So Sujata, today I'm going to ask you questions related to tubal infertility. Can you enumerate what are the common conditions that cause blockage of tubes and some of the solutions that are available for that?
Good afternoon, everybody, and happy Women's Day to all of you all. The most common cause for infertility that we see, the first thing coming to our head is about the female infertility is tubal factors. And the most common thing for blocked tubes is, in India, we consider tuberculosis as one of the main causes. The other causes could be endometriosis, could be previous surgeries, abdominopelvic surgeries, and lastly, infections, untreated PIDs and everything. The most common cause being tuberculosis in India is because of the 25% of extrapulmonary tuberculosis, 9% is genitourinary in India. So 9% population is quite a big burden for us to treat. The most common thing is that with tuberculosis is that it's a bacillary disease, so it's very difficult to diagnose unless you are very keenly looking into it. So the most common thing that we would look for in a couple when they come with a history of blocked tubes, with a history of not having conceived, we should be very astute enough to pick up signs that, okay, there is no history of tuberculosis. Normally they come with a history of ectopic pregnancies, or they will have a history of past exposure to tuberculosis, or they are in the group of people who are in the high risk of exposure to tuberculosis, like doctors, dentists, people working in the ICU. Earlier, tuberculosis was considered as a disease of the lower income group, but now it is not so. It is also seen in the higher income groups and the middle income groups. Basically, it is because of the exposure and the lower immunity status of the person. Now, coming to endometriosis, yes, endometriosis can be picked up more frequently than tuberculosis because women do come up with symptoms of pain during periods, so they are picked up more easily and more early in their diagnosis. Now, coming to tuberculosis, the main thing is that we should be very astute enough to pick up the disease and treat it early so that it doesn't cause end organ damage, because it's a permanent damage, whatever it causes. And then we can also reduce the poor fertility outcome in these people if they come early and we can pick up the diagnosis early. Other causes for tubal things is maybe previous surgeries. Yes, that is a part of which we can be taken care of with good surgical care and all that. But yes, IVF offers a benefit for all these blocked tubal factors.
Dr. Sujata, we see endometriosis more and more today in our country, and we are seeing this at an even younger age. And we see when we do a laparoscopy that many of these women not only have endometriosis, which causes a problem with the ovaries. You see large kissing ovaries, which are called chocolate cysts, but these also affect the tubes. So can you shed some light to the audience about how endometriosis, fibroids can cause inflammation and thereby block the tubes?
Endometriosis is basically an inflammatory, it causes inflammation inside the pelvic organs. It causes decreased motility of the cilia, further blocking the tubal factors and all that. Collection of chocolate fluid on the ovaries and the tubes and the pelvic organ distorts the morphology of the whole pelvic system, thereby causing infertility. So in these cases, surgery, yes, if the cysts are big enough and they're looking for fertility issues, then yes. Otherwise, newer medical treatments are also available for endometriosis that can be used. But the most recent thing is that if the endometriosis, we know that the ovarian reserve comes down. So it's better to offer them a newer technique of ovarian cortex freezing in these women so that they have the ability to build up their career at their own pace and then have choice of having motherhood at their own age when they want to have it.
We now go on to our last but not the least panelist, Dr. Madhavi Panpalia, who is also a very senior consultant. And Madhavi is going to shed some light and give us some instances of the new technologies. As you know, at Jaslok, we are pioneers in all the new technologies that are present and available in India. We had the first ICSI baby in Southeast Asia way back, many, many years ago. Today, this little baby who was so little, Love Singh, has his own baby, and Love Singh insisted that his baby be born at Jaslok, just as he was born at Jaslok. Madhvi, please enlighten us about some of these new techniques.
Thank you, Dr. Parekh. A very good evening to everyone on and off the dais, and happy Women's Day to all of you all. Everyone is now saying that, of course, infertility is on the rise and IVF is on the rise. So what new do you have? What is the latest that you have to offer? I begin by saying that now this is the era of personalized medicine. So we are going to be helping the woman by giving her stimulation individualized to her because of her particular parameters that she has. We will design a protocol which suits her most so that we can get as many eggs, or I would say optimum number of eggs from her. And as you know, more the eggs, more the embryos, and more the cumulative pregnancy rate. We also have a better culture media. We can now take these embryos to day 5 stage, that is the blastocyst stage, or the final stage. So it increases our pregnancy rate. Finally, we also have better technologies for freezing and thawing of the embryos, eggs, and sperms. This is very important because it will allow people who want to voluntarily postpone their parenthood. They can freeze their eggs and use it at a later age, or people who've undergone IVF and have many embryos created, they can come back for their second baby. They don't have to undergo the entire stimulation and the pain of taking the injections again. Or we can also, for people who are undergoing some kind of cancer surgery, they can preserve their eggs or embryos if they are married, or the sperms in case it's a male, so that they can use it when they are done with their chemotherapy. Now we also have special techniques in which they can prepare the sperm which is going to be used for ICSI. This is known as the microfluidics technique, in which it is a slide which contains channels from which we can obtain the sperms which are more healthy and fertile and have the least DNA damage. Now, all these years, we have always talked about the sperm count, motility, morphology, and very little was given to the DNA integrity. Now, there are studies to show that if the sperm has high DNA integrity, the quality of the embryo so formed is very poor. So obviously, if it's a poor embryo, the chances of implantation are less. And now there are studies to also say that they may contribute to abortion rates. So when we are using this microfluidics technique, we are bringing down the DNA fragmentation rate of the sperms, and we are getting good quality embryos, and that is why it is increasing our pregnancy rate. We should also talk about, we have some special chambers called VD chambers. We know that when we are freezing the sperms and when we are bringing them back to room temperature, a certain portion, or I would say a significant portion of the sperms are lost. Now with this VD chamber, the recovery of the sperm is very good. So this is particularly helpful in people who have very low sperm count, or in whom we have taken the sperm directly from the testes, like when we do a TISA or a PISA. So this will help us in creating more embryos and thereby increase our pregnancy rate. There is also a technique that was pioneered or developed by Dr. Feroza Parekh and her team called cumulus aided transfer. Now, cumulus cells are cells which surround the egg at the time of ovulation. Now, during the oocyte retrieval, these cells which are usually there are discarded, but we culture them in the lab, and the embryo is co-cultured along with these cells. They provide nutrition and growth factors which facilitate the growth of the embryo, and thereby it increases the chances of pregnancy. It is more helpful in cases of women who are of an elderly age group, or where we are getting less number of eggs. So this was a technique which was developed by Dr. Firoza Parekh and her team at Jaslok Hospital and Research Center. Coming to the next important, as my colleague Dr. Sapna has already narrated about the pre-implantation genetic testing, which we offer in Jaslok and which has increased the pregnancy rate, particularly in women who are more than 35 years of age or who are carriers of various genetic disorders. We also offer IMSI services in our hospital. When there is a severe male factor infertility, we can do what IMSI, which is intracytoplasmic morphologically selected sperm injection, in which we magnify the sperm to more than 7,000 times. And thereby we can choose the most normal looking sperm to be injected for the ICSI. This also helps in creating better embryos and obviously thereby increasing the pregnancy rate. We also do laser assisted hatching that will, especially in people who have elderly age group or who have recurrent implantation failure, we make a small opening in the outer layer through the laser, and that also helps the embryo to implant. Now moving on to, we all know that males contribute to 50% of the infertility, and the sperm is an important factor where we have dealt with count, motility, morphology, DNA integrity. But when the embryologist is choosing the sperm for the ICSI, he's actually doing it manually. So now we have the technique of artificial intelligence with machine learning algorithms, which will help aid the embryologist to select the best sperm to do the ICSI. That is why we can have better quality embryos. And obviously, if it's a better quality embryo, there are better chances of implantation. The same technique can also be used for embryos, because then the embryologist can decide in a fast, objective, and accurate manner which embryo is good and has a better potential for implantation. So if we choose that embryo for pregnancy, obviously the pregnancy rate is better. The embryoscope or a time-lapse technique can also be used. It helps in the doctor to directly see in real time the growth of the embryo. That will then help us to determine which embryo has the maximum fertility potential.
Thank you, Madhuri. That was a very nice summary of all the new things and techniques that we are doing at Jaslok. I will like to leave you all with one message. And my take-home message to you all is, first of all, of course, thank you for being with us and joining us, is fertility is time-bound. To all the young girls who are watching us, my request is, do not neglect the golden opportunity of fertility, which is peaks between the ages of 24 and 34. Use this time to at least freeze your egg if you're not ready to have babies at that point. If you're married and you don't want to have children immediately, freeze your embryos. That is the best birthday gift that you can give yourself. At the age of 38, if you decide to have children, then your 28-year-old embryos will be happy and more healthy than if you were to have 38-year-old embryos. Thank you again for joining us, and really, really happy to have contributed to Women's Day today.
Thank you, Dr. Firoza Parekh and her esteemed panelists. It was a wonderful discussion and so much of knowledge sharing. I think all of us now really know what infertility is all about. Jaslok Hospital is very proud to have Dr. Firoza Parekh with us, because she is the one who's been responsible for so many firsts in different procedures for infertility, not only in the country, but also in the world. Thank you so much, Dr. Parekh and the team.
Thank you,
Jonai.
We'll give you token of appreciation.
Thank you.
Thank you very much, ma'am.
Thank you so much. Thank you.
While we move on, to the panel 2, Strength in Womanhood, Navigating the Journey of Wellness. It encapsulates a powerful and multifaceted exploration of the physical, mental, and emotional aspects of women's well-being. The journey of wellness for women is a dynamic and evolving process. By embracing strength in womanhood, acknowledging the interconnections of physical and mental well-being, and fostering a supportive community, women can navigate their unique paths to holistic health and fulfillment. The next moderator for our session will be Dr. G.N. Mansukhani, Director Obstetrics and Gynecology. Dr. G.N. Mansukhani, Director of the Department of Gynecology at Jaslok Hospital, comes with a rich experience of over 45 years. She graduated from Calcutta Medical School and then proceeded to UK to do her basic and advanced training in obstetrics and gynecology. She took her membership from the Royal College of London and stayed on to get further experience in her field. She is trained in laparoscopy and complicated maternity cases in several hospitals in London. She acquired training in ultrasound (SCAT) at the University College Hospital in London and was responsible for the ultrasound Centre in Obstetrics and Gynecology at the Hillingdon Hospital, London, which was an 800-bedded hospital then. She returned to India and joined the Jaslok Hospital and has been here for nearly 5 decades and started the ultrasound department at this hospital and has been dealing with high-risk pregnancies since then. She keeps herself abreast of advanced technology by going to international workshops regularly. Dr. Mansukhani has also been taking lectures for medical students who are proceeding for postgraduate studies, both locally as well as internationally. She also takes lectures for medical practitioners. The department has acquired a newer maternity ward and labor room, and she's overseeing the efficient functioning of this. Along with Dr. Mansukhani will be our esteemed panelists, who are the stalwarts in their own field of expertise. Dr. Sudeshna Ray, Coordinator and Consultant Gynecology and Obstetrics, Dr. Purnima Satoskar, Consultant Gynecology and Obstetrics and Expert in Fetal Medicine, Dr. Shilpa Agarwal, Consultant Gynecology and Obstetrics, Expert in Fetal Medicine, and Dr. Nidhisha, Consultant Gynecologist and Obstetrics. We will soon be having all of them in the panel.
Good evening, everybody. Welcome to this panel discussion. I'm Dr. Mansukhani, and I have my team of expert colleagues with me
who have been working at Jaslok Hospital for a fair length of time and who are experienced in our field of gynecology and obstetrics for a fairly long time. Having practiced myself for a long time, I can see that the women of today have a major role to play. They are not only rearing children or bearing children, but they are also working women. So they are also supporters of the family and the breadwinners of the family. As a result, I feel as a gynecologist and an obstetrician, we have a very major role to play to make sure that our women remain healthy and can face both fronts, both on the working side as well as on rearing a healthy family for the future generation of India. Earlier in the years, we used to have the dowry system, and therefore people were rather reluctant to have female children. And we do hear stories of certain villages where there was never a palki taken up from that village because they did not want to have a girl child. And having seen these stories and seeing how we have progressed forwards with education and women's empowerment, I have several women who deliver with me, and if I tell them their first child is a baby boy, they may sometimes tell me, no, I wanted a girl. I can tell you that over the years, having seen 3 or 4 decades of families, that it's usually it's the daughter of the house who is taking care of the parents, and the sons are probably gone abroad or somewhere else. So I can tell you that we women have a very major role to play as gynecologists and also looking after the family. So now I will pose my first question to Dr. Purnima Satoskar. We are going to take you through a woman's life stage when she's a kid, when she progresses, and when she gets old. So we will go in that manner, and we'll ask Dr. Purnima Satoskar, who's sitting here, that Purnima, how do you feel that things have changed and the ratio of women is to men has been altered in the earlier years when they were not wanting to have girl children? And do you feel that things have changed now, and the government having stepped in, having introduced the PCPNDT Act, has that changed matters? Can you throw some light on it?
Yeah, so scientifically speaking, we all know that with every pregnancy, there should be an equal chance of either a boy child or a girl child. So the ratio at birth, if you look at it, it should be 1:1. Now, what happened in olden times was that we all know that there was a preference for a son in our society. So couples would go on having children until the son was born. Subsequently, in the 1990s, what happened was ultrasound machines became available, and it was possible to determine the sex of the child while it was still in the womb. And this then gave an opportunity for some of the people to, selectively eliminate the female children. And this started skewing the ratio much more. So this came to an all-time low sometime in 2005, where instead of 1,000 females to 1,000 males, there were 880. That was the lowest that we have had in India. And the government had realized this, and in 1994 it came up with the PCPNDT Act, or the Preconception Prenatal Diagnostic Techniques Act, which ruled in these diagnostic techniques and tried to prevent sex selection. So in this act, the woman, whenever she's undergoing ultrasound, has to sign a consent form that she's not going to ask the sex of the child. And at the same time, the doctor also has to give an undertaking that they will neither detect nor reveal the sex of the child to the couple. And because of this and another good venture which the government came about in 2015, which is known as the Beti Bachao Beti Padhao Andolan, which raised a lot of awareness in society that girls are precious and they should be treasured and they should be celebrated. And the aim was to protect the girl child and to encourage her education and make her independent. So that started again showing gave good results. And the ratio has now gone up from about 918 in 2015 when this was launched to almost 933. So we are on our way up, and we hope very soon that the ratio will be equal, which is as how it should be in society.
Thank you, Purnima. So now we come to realizing that the government has tried to improve the ratio of the girls to the boys that are being delivered. And now we'll move on to the teenagers. So I'll request Dr. Sudeshna, who has started a special group called the Lighthouse Group for teenagers, to deal with the problem of teenage girls. So Sudeshna, can you tell us what are the problems that you face with these young girls coming to you?
Right. So these young girls are the base of the adult women that you were talking about. The responsible women that we are talking about, we all start with the teens. And there is a difference that we have seen in our practice also, how the teens were 20 years back and how the teens are now. They are more empowered, they are more global, they are exposed to a lot of information. There is a small lack in assimilation of that information into a proper knowledge. And that's what we are here for, to guide them and to make them, channelize their knowledge, their information, what they get from everywhere else into a meaningful health journey. So what we face is, as a teenager, what I think the most important thing of the decade right now is the lifestyle problems. The lifestyle problems of having not so active life, not giving importance to sports, and having a little more of a sedentization than activity. So that leads to a lot of hormonal issues, hormonal ups and downs. Then we have something called the polycystic ovarian syndrome, which is very, very common these days. It's like an epidemic nowadays. It's not that we have created it, but it's probably an imprint with which the girls are born, but with their sedentary lifestyle, with their disciplined sleep routine, and with Zomato and Swiggy at their fingertips. I think this is something which has kind of activated the whole journey of hormonal imbalance. So this is the commonest thing, and this leads not only to physical problems or period issues, they also lead to psychological acceptance problems. So they get a little obese, they get fat, they have a lot of pimples, they have unwanted hair. That leads to psychological problems as well. These, barring the hormonal imbalances, they're also that nowadays teenagers and the young adults are also more uninhibited about certain things which were they inhibited about 20 years back. For example, having a little more freedom in choosing their partners and in indulging in sexual activities. That leads to sometimes, if they are not very careful, that can lead to sexually transmitted infections and unwanted pregnancies. So these are the things. The other main thing that we see, and this should go as a very important message to all of you listening to us, is we understand that period pain is normal at this age. However, there are certain period pains which should need a proper attention. For example, period pain which lasts throughout the periods, period pain which needs more than one tablet of painkiller, period pain which makes the girl or makes the young adult not attend school, college, or work for some time. So all these kinds of period pain which is associated with these kind of absenteeism or need for more and more analgesics, they are not normal pains. So please, all of you hearing us should make it a point to understand that all period pains cannot be normal. Most of the period pains are normal, but if you feel that the period pain is really, really bothering you, please ask your parents or please go to a gynecologist and get yourself checked as to what is the cause of it and take the proper treatment. So these are the usual things that I think the young adults and the adolescents these days feel. If you have anything else to add.
I was wondering whether you could talk of any menstrual irregularities that you see, because mothers come worried to us at the age of 13, 14 that their periods are not regular.
Yes.
So do you think it is something that they should worry about?
Right. So it is, that's a very nice thing that, so in the young, when you start your periods, that is called a menarche in our medical language. So about 2 to 3 years following a menarche, we really don't bother about the irregularities of the period, because it takes a little time for the entire coordination to happen, and we have to give them time. However, even at this stage, the diet and the sleep and the sports are important, have important roles to play, because that lays the foundation of what is going to happen after 3 years of menarche. So it is important that we identify, we understand that this is not a problem. We take care of our lifestyle, but if after about 3 years they are still having irregular periods, they are having acne or stubborn acne, or they are having a difficulty in their weight management, then it's time that they see a specialist and get them sorted out.
Thank you. So, Dr. Nidhi, now I'll ask you, since you are handling the vaccines, since India is manufacturing vaccines and is advising that all young children should have them after they have achieved their menarche. What do you have to tell us about the vaccines?
So,
indication.
The cervical cancer prevention vaccine, that is the HPV vaccine, is what we are talking of here. Now, HPV is a sexually transmitted disease, and it is responsible as the causative agent for 100% of cervical cancer cases in our country. Thankfully, we have a vaccine which is directly targeted to the cause, that is the human papillomavirus or the HPV. Now, there are different types of HPV, more than 150 types, but there are around 14 high-risk HPV types, and that's where we the vaccines target these high-risk HPV subtypes. Now, they were developed in 2006, and we have vaccines from as early as 2008. That they've been licensed for use in our country. We initially had Cervarix and Gardasil, which was introduced in 2008. Then in 2018, we got the Gardasil 9, or the nonavalent vaccine as we know of it. And very recently, in September 2023, the Serum Institute of India in Pune, they have started manufacturing the very first Indian cervical cancer vaccine. It is known by the trade name Cervavac, and that has really increased our chances of reducing the cancer cases, because it's going to be very cost effective. All this time, though the government knew there was a vaccine, we couldn't introduce it in our immunization schedule because it was imported, and the cost of each vaccine ranged from 4,000 rupees to as much as 11,000 for a nonavalent vaccine. But with the Cervavac being manufactured in our country, the cost has come down to almost 1,000 to 2,000 per injection, and that's why it's going to be a game changer. The license age for the vaccination is from 9 to 45 years for all vaccines except the one which has come out by India. We've got license for 9 to 26 years, which is actually ideal, because post this we would like to concentrate more on screening than vaccinating the adults. Now, the vaccine can be taken both by girls and by boys. So it's been licensed because it helps to prevent 6 types of cancers, and cervical cancer is just one of it. It also prevents vulval, vaginal, anal and laryngeal cancers in women, and even the penile cancer in men. So it is fantastic that it is marketed both for boys and girls. Dosage schedule is if you are going to give the vaccine to a 9, so it's being targeted for the age group of 9 to 14 years. That is on time or the ideal age for taking the vaccine, and you have to give your child only 2 doses 6 months apart. If it is if your child is beyond 15 years, up to 26 or even up to 45, if you're taking the non-valent vaccine, you have to give the child 3 doses, which is at 0, 2 and 6 months, but within a year max. So this is the schedule. We do encourage a lot of vaccination to be taken between 9 to 14 years. And we have a lot of parents coming to us asking, why should we give it on so early? Because at this point, the child is not sexually active. And why would you want to give a sexually transmitted disease vaccine to the child? And the answer to this is that best immunity develops when the child is young. So we've checked and done a lot of studies on antibodies, and we've come to a conclusion that when you give the vaccine between 12 to 14 years of age, you have almost 100% chances of preventing the pre-malignant cancer and almost 87% cancers of cervix in the child. Whereas when you give it a couple of years later, which is almost like at 17 years and beyond, the ratio of antibody drops to almost 50% protection. And when young adults take it beyond 30, 35, we've seen that the antibody levels drop to 30%. And hence the Survivac has been marketed for 9 to 26 years of age. So the earlier you give, the better. Also, some parents come to us and ask us what will happen to the fertility of the child in future. So it is a very safe vaccine. The vaccine has been in the immunization schedule for all the other foreign countries, and millions of children have taken it. There are no long-term side effects. The only side effects you see is the immediate side effects of the injection, that is maybe a little bit of swelling or a little bit of redness or minimal fever. Very rarely you will see a little gastrointestinal complications, but other than that, you do not see anything. And it does not affect the fertility of the child. In fact, it protects the fertility because you're preventing any cervical pathology.
Thanks.
Yes.
Thank you very much. So now we see that with education, the girls have been going out to foreign universities. We see that girls have been going out to work in various cities. So, Shilpa, do you find that the incidence of unwanted pregnancies has increased compared to what you used to see earlier?
Yeah. So yes, to see now when we are in our OPDs, we see mothers coming that, doctor, I got my periods when I was in 10th standard, but my daughter got it at the age of 8 or 9 years. So we are seeing early puberty due to the maturity of the hormonal axis. So yes, the puberty is early, and that is the reason why we have the sexual activity also happening too early in the age group. And as the sexual activity is on the higher side, there are definitely chances of unwanted pregnancies. So we do see unwanted pregnancies, but yes, we also, on one hand, we have unwanted pregnancy, but on the other, we also have good methods for termination of pregnancies where we can do it medically only under the guidance of your gynecologist. So yes, we do see unwanted pregnancies, but we also have methods for doing it safely under the guidance of your doctor.
Can I add here one thing?
Yes.
I was, this is a discussion that we are doing, and the change that we have all seen in our practices, that 20 years before, 25 years before, I would see a girl coming in very scared and not able to discuss this with anyone else. And then I have seen girls coming in with complications because they have gone somewhere where their friends have told them, and not like a proper place for termination of pregnancy. So this is a good thing that we are seeing now, that these girls are brought by their mothers, by their parents, by trusted friends who understand the importance of going, as Dr. Shilpa said, that going to the right person to get the right guidance. So this is also something which has to be encouraged, that you have that communication with your children or with your friends, that they should be able to come and tell you whatever happens, so that you can guide them rightly, so that they get the right guidance, as Dr. Shilpa said.
Yeah, I think in summary, it is like we are more confident. The girls are more confident about their body and about the options available to them.
Yes.
And I must say this also, that neither the girls nor the parents are embarrassed at saying that she is having a relationship, although she may not be married, you see. So it's nice of them to understand the situation. Absolutely. Because the world has changed considerably, you see.
Absolutely.
So can you tell us something about contraception then? How do you guide them?
Yeah, contraception is definitely a very important point in our practice. We do encourage contraception. So as we said that the sexual activity has increased, the use of contraception definitely should be understood by everyone around. And we know that barrier contraception is what is commonly being used. Yes, it is a good method to prevent sexually transmitted diseases, but at the same time, we should understand that the failure rate or the chance of having pregnancy after using barrier contraception is still high. So we have to understand the failure rate of barrier methods, and that is why we encourage the use of oral contraceptives, that is OC pills. People generally have a myth that OC pills are not good. They will increase their weight or they will cause side effects. They will cause side effects only when used at wrong time, wrong dosage, and by a wrong person. So it should be correct person, correct time, and correct dosage. And that is how we can make the maximum use of all methods of contraception. So yes, barrier methods. And one thing I want to just stress here, that no, we should avoid and we encourage our patients not to use IPIL or emergency contraception. So it should be the least used method, whereas many of them, they misunderstood it as a method of contraception on a regular basis. It should not be used on a regular basis.
Thank you. So, Sudeshna, now that the woman is married and she is ready to consider about having a pregnancy, do you think that they should come and meet you prior to thinking of a pregnancy, so you can plan their bodies, their health before they try?
Yeah. So that is one of the most important things that you should start your planning of pregnancy with. So when you're planning a pregnancy, people usually start planning their finances, start planning, they're staying together and their logistics around, but they don't plan about health. So that is where we come in and tell them that this is the time when they have to meet as a couple. We will encourage them to meet the gynecologist as a couple to understand how to optimize their health before they embark on the pregnancy, because the pregnancy is a time where they are giving the healthy start, the biggest health start to the baby that the mother is carrying. So that is a time when we do certain tests, like to see the iron levels, to see the thyroid levels, to see the sugar levels, and sometimes we get surprised that they don't know that they already have a thyroid problem or a sugar problem, and that needs to be addressed before they can get pregnant. Optimization of the weight. If they're underweight, bring them to a proper weight. If they're overweight, then cut down the weight to a proper weight, because during the pregnancy, we can't have any weight management. Also, vaccinations, because there are certain infections that we need to check how immune are these women to these infections, because these infections, if they happen during the pregnancy, they can have a lot of harmful effects on the babies, especially something like deafness or blindness, which cannot be even picked up on a sonography. So these are the infections that they can be vaccinated against, and we encourage them to do some tests to see whether they need those vaccinations or not. Similarly, blood things like thalassemia, all these things can be screened before they can get into pregnancy. And then they should start thinking about. Also, the folic acid supplementation, which decreases the risk of congenital abnormalities, the birth defects in the babies. So that prenatal vitamins also need to start.
Just to add here, addictions is what though we used to think that in India we should not take that history or we see less addictions, but I think yes, nowadays we are seeing addictions in females, and that is what we usually tell them to stop alcohol or smoking before they embark on the journey.
Even recreational drugs.
Yes. So could you now tell me, Shilpa, whether how often do you expect them to come for antenatal care? What do you look out for so that they have a smooth sailing during the pregnancy and have a healthy baby and maybe even a normal delivery?
Yes. So like how a marriage, before marriage, there is a big preparation in the house where everybody is doing everything to make the marriage, to make the whole ceremony very beautiful and successful. The same way, pregnancy, the foundation should be strong to have a good building. So when the foundation is good, we will have a strong building ahead. So antenatal care in the first trimester onwards is very important. We usually see patient coming after the end of first trimester because they feel that initial 3 months they should not tell anyone about the pregnancy. But that is a important thing which we all would like to bring here, that please get yourself checked as early as your UPT, your urine pregnancy test is positive, because now we have very specific tests at 3 months of pregnancy, at 11 weeks, where we do very important tests which cannot be done in the later part of pregnancy. So I really urge everyone here that please get yourself checked whenever your urine pregnancy test is positive, because you might miss important tests if you do not do that. So till 12 weeks, we usually say that initial 1 monthly checkup, we call them to do all their routine checks and we see if everything is healthy. Then we do their anomaly scan where we see the baby at 20 weeks, around 20 weeks. And till 28 weeks, the checkups are not very frequent. We call them around, say, 3 to 4 weekly, depending on their condition. After 28 weeks, it is usually every fortnightly that we call them, and check their blood pressure, check their weight, check their overall growth of the uterus. And post that, usually after 32, we recommend to call them every weekly till they deliver. So yes, antenatal care is a very important aspect of a normal baby and a healthy child.
Yeah. So we must make sure that they come regularly and that they do not miss out on any antenatal visit, because each visit is so important. So now that you see that girls are being educated and then they are delaying their marriages until they find the right partner, I find that whenever they come to us at the age of 34, 35 and they say, we're trying for a baby, I tell them, didn't you think about your biological clock? And they say, no, we never thought about it. We're trying to make sure that we were, getting ourselves settled. So now, could you tell me the problems that people encounter when they're having pregnancies at a higher age group?
Well, at a higher age group, some of the diseases which run in the family, like diabetes or hypertension, that is increased blood pressure, they are bound to come up at the age of 35 plus. So these, when the girl becomes pregnant, then sometimes these diseases manifest themselves. And also things like thyroid diseases, which are thyroid problems, hypothyroidism is very common in women between the age of, say, 30 to 40. And they may not be aware of it, like Sudeshna mentioned. So when we see them for the first time in pregnancy, they are surprised to find out that the thyroid is sluggish. And it's very important to supplement the thyroid hormone so that the brain development of the baby takes place normally. So the earlier we detect these problems and we control them, the more beneficial it is to the mother. And in some of the cases, there is something known as preeclampsia, or it's a specific type of blood pressure which happens in pregnancy, which is really very dangerous for both the mother and the baby. And it can lead to convulsions in the mother, or it can lead to the baby not growing properly and requiring prolonged neonatal ICU care. And so this is another thing which we need to be aware of when the older mother is coming to us. And we were talking about screening in early pregnancy, which was very important. So one of the things which you can screen for is preeclampsia. And just by giving a tablet starting at 11 or 12 weeks, just taking a tablet every day, it can be prevented. So although the age of the mothers is increasing, if they come to us early, many of the problems can be tackled at an early stage. Also, the body weight tends to be a little more in these girls who are older, and because of they've got used to the sedentary lifestyle, so they need to be warned about that also.
So, do you think it's important, Shilpa, that the ladies should register, or these women should register in a particular place where things will be safe to make sure that we can take care of the child?
Yes, definitely. Now we are very comfortable delivering our mothers, high-risk mothers at Jaslok Hospital, because we have everything under one umbrella. So we have, starting from, as we heard from Dr. Firoza about the infertility, we have everything starting from a very good ICU care, a very good maternal ICU. So I am very confident when I deliver a mother with severe blood pressure or with severe problems, liver problems, to deliver them at Jaslok Hospital, because we have a very good ICU and intensivist care here. And blood bank facilities are available. We have a very good sonography department where each and every fetal medicine aspect is taken care of. So we have ultrasound, a very good ultrasound department, a very good ICU care. And we have a very robust team of anesthetists, which is an integral part when we do any deliveries of such high-risk mothers. We have a very great team of physicians, a team of anesthetists, a big team of sonologists, fetal medicine experts, and we have very special clinics running at our hospital. We have adolescent clinic, we have lighthouse, we have colposcopy, we have twins clinic where we are seeing only all twin pregnancies in our special OPDs. We have menopause clinic. So we have all other clinics associated at Jaslok Hospital. Endometriosis clinic is also there. So we take care of gynec, obstetric and infertility part of the treatment.
So, adding to that, this is something which we all have faced, that as these pregnant women comes and asks us about what is the cost and all. Of course, these hospitals are expensive, but expensive than the general nursing homes or the smaller nursing homes. And we probably as doctors will earn lesser than what we would earn in a smaller nursing home. But for us, institution matters, and the safety of the mothers matters the most. We feel that in an institution like Jaslok, we can give the utmost safety to the mothers. So I think it makes a lot of sense to persuade them to choose the right place of birth in an institution. Isn't it, madam?
Yeah.
And to add, we have a very close-knit team of obstetricians out here. So we have a obstetrician 24/7 in the hospital, and everybody is just a phone call away. You call somebody and we all are here to help each other.
Everybody, like medicine. So any complication we can deal in with the snap of a finger, which in a smaller place is a big challenge. To get someone as an expert from somewhere else, it's a big challenge.
And if they are from far, I think they can also avail the teleconsulting facilities for some of the visits and cut down some of the visits if they want to show us.
In fact, we have a very good physiotherapy team also now. So, and lactation specialists. So we have everything under one roof. So it's fantastic.
Yeah. I must say that there have been people who have felt they couldn't afford Jaslok, but they've had bad experiences elsewhere. They've lost their babies, and then they've come here, to have their babies, and we've given them a live baby to take home. So that has made a lot of difference. Okay, next I will, I'll speak to Sudeshna and ask her, what are the problems you see in women who are reaching their 40s, medical problems that you see commonly? Because now the time when she starts having gynecological problems.
Yes. The commonest gynecological problem that they face above 40 is the menstrual irregularities. They might have episodes of very heavy bleeding or skipping the periods, or sometimes, like frequent periods, like periods are coming every 15 days or so. While most of them are perimenopausal problems, like because perimenopause means you're expecting menopause in the next 4-5 years, you've started having those problems. However, there are certain criteria of these problems which only the experts will be able to understand. So it's very important, if you're having a problem which is bothering you for several months in a row, please see your gynecologist, please see the doctors, because you might have something which can have a long-term problem. Like 9 out of 10 will be hormonal issues around the perimenopause. 1 out of 10 will be a precancerous problem. So, or something like a fibroid which needs to be addressed, something like we call it as an inflammation which needs to be addressed. So all this should be seen. Of course, the like premenstrual symptoms or perimenopausal symptoms of anger, anxiety, depression, feeling low, hot flashes. These are also the problems in their 40s, which I feel as a kind of family needs to be addressed. It's not the woman's. It's not always the woman's. It's in control of the woman, but the family should understand that there are changes that hormones are responsible for, and they should be dealt with sensitively.
Thank you. So now, Nidhi, we've come to a woman who's reached her age of 50 and she may be going into menopause. What are the kind of complaints she comes to you about? And then can you cover a bit of cancer also as she heads for 60?
Yeah, sure. So basically, menopause is a natural phenomenon, and the average age in India is lesser than the global age. It's around 46.5. Of course, globally, it is around 51 years. So we do have an early menopause. The change is... the diagnosis of menopause is a clinical retrospective diagnosis when we can say that a woman has achieved menopause when she doesn't see her periods for a year. At least 12 months when she hasn't seen a period, she's achieved menopause. It may be smooth for some, but it can be really nasty for some. Symptoms such as hot flashes, as Dr. Sudeshna said, can be really annoying, especially at night, leading to disturbed sleep pattern, increased sweating. You may have stress incontinence, you may have vaginal dryness, and therefore sex is very painful and not pleasurable. Women suffer from increased cardiovascular diseases, Alzheimer's disease, and of course we do have mood swings, a lot of anxiety, irritability, and sometimes even depression. So these are just few of the symptoms that women do experience. And yes, a lot of them are worried about their skin because there is overall reduction in fat. So the skin starts sagging, the glow, there can be hair fall, there can be
pigmentation.
Yes, there can be pigmentation. So that is one of the major concerns that women come up to us with. But what really is worrisome is also the bone health, the protection that hormones give the bone and the heart. Those are two worrisome things because there is even a small fall can lead to fractures, especially of the wrist or the spine or the hip joint. And hence we see an increased number of women coming with fractures or with heart ailments. So these are to name the symptoms. Yes, we do encourage a lot of annual blood tests in these women, and we encourage doing a DEXA scan to check for the bones, whether there is osteoporosis or osteopenia, basically checking the calcium levels, especially at these three major joints. So that is something that is recommended. As far as treatment is concerned, lifestyle modification, eating a healthy diet, including weight-bearing exercises, because that will strengthen your muscles. If the muscles are strong, it will protect you against those small, tiny falls, which would have otherwise led to a fracture. And incorporating calcium, vitamin D, and some form of B12 if you are a vegetarian in your diet helps. And last of all, we do have medical hormone therapy. Now, it's not very well accepted in our country. That's because there's a lot of fear, and there were a lot of studies earlier when the doses used were not correct and were high. But a lot has been studied into it, and if used for the right women at the right age, in the right dose, and for the right duration, and also the right mode of giving the medicine, then the route of application, then I think MHT really helps. It is ideal to start within the first 10 years of menopause, and we do not recommend it beyond 60 years of age. So that is something that can be looked upon. Of course, we also have a lot of natural products that are available, and the obstetrician might start you with some herbal medicines. She will give you multiple options. So I think visiting them, being very frank about everything that you're suffering from, will really help you a long way, because post-menopause, now that life expectancy is increased, we do have substantial years of our life, and they need to be smooth, because these symptoms can really alter the quality of life of a woman. So that's as far as menopause is concerned. And cancer, of course, there are 4 major cancers that women suffer from. Cervical cancer, it's a leading cancer. It affects 20% of global cancers. India affects 20% of the world's cancer for cervix. Also, the breast cancer, 1 in every 8 women is going to develop breast cancer in our city. And we have the endometrial, that is the lining of the uterus, and the ovarian cancer. So these are the 4 cancers which we commonly see in women. As far as screening goes, fortunately for the first 2 cancers, breast cancer and cervical cancer, we do have substantial screening. Breast cancer, we have mammograms that we can do. We recommend mammograms from 40 years to annually from 40 years to 55 years, and then once every 2 years post 55 years. Of course, we know that breast cancer runs in families in addition to other factors, and hence if you do have a family history, you need to visit the gynec earlier, because we see that they need to start screening 10 years earlier than the age of breast cancer that family member had. So there's something called as risk assessment. So the best person to go would be your gynec or a surgeon, and they would guide you on that. As far as cervical cancer screening is concerned, there are 3 pillars to it. We do have the pap smear. Now, a pap smear can be of 2 types. There's the conventional pap smear, which is done once every year, or there's a liquid-based cytology, and the frequency is once 3 years. So you can do either of this. Basically, it is screening of the cells under a microscope and looking for any abnormal changes in the cells. The second part is directly targeting the HPV virus. So we have what is called as the HPV test. It is the most accurate test and the most specific test for cervical cancer screening. And the best part is it has a fantastic negative predictive value. If you have a negative report, it is very reassuring, because then you know that you're not going to develop cervical cancer for at least the next 5 years. And the frequency is once every 5 years. So whatever fear people have of visiting the gynec, especially somehow once they've delivered, they don't want to visit the gynec for any screening or anything until they have some problem with their menstruation or menopause or etc. But screening is extremely, extremely important, and it's very simple. Pap smear is not painful if it's done in the right manner by the right person. It's about how gently you do it. And last of all, we have colposcopy, which is something that I deal with, and we have a clinic at Jaslok, as Dr. Shilpa said. And colposcopy is basically trying to confirm from an abnormal pap smear or an HPV test whether you genuinely have the abnormality, because we look at the cervix under magnification and we look for vascular changes. And the good part is that you can also get a biopsy taken there, and it can be done as an outpatient department procedure. So we do not have to go to the OT in daycare and take a biopsy. It can be done very easily. So that's about cervical cancer, endometrial cancer, sonographies. We have fantastic sonographies, and they will tell you whatever abnormalities you can see in the lining. And of course, a hysteroscopic dilatation and curettage can be done. The silent cancer is the ovarian cancer. It generally is diagnosed very late, and hence your annual sonographies that we recommend in post 45-50 years, that will help us to see the ovaries. Unfortunately, there's no specific screening test as of now for ovarian cancers, but sonography does a fantastic job. So if it's done at the right place by the right person, we will pick up what needs to be picked up. So yeah, that's about
yes,
cancer.
thank you everybody. I think we've gone through the whole stage of her life, the woman's life, and the problems that she faces. I still feel that having nuclear families alone is quite challenging for a woman. I know that you get a lot of maids to help you, or you have home help, but there's nothing like a family support. Having had your seniors, grandparents for the children, all that has very great value in spite of the modern trend of living. And one thing that I would advise is that women very often Google and come and have very often things to say that are not applicable to them, so they worry unnecessarily. So they should come and discuss it with their doctor rather than looking at the Google page. Thank you.
Thank you.
Thank you. Thank you very much. Thanks for listening to us.
Thanks,
What a
Jyoti.
beautiful panel discussion. What a beautiful panel discussion. Very knowledgeable. For every stage a woman passes by in her womanhood. Dr. Mansukhani and team, thank you so much for this wonderful panel discussion. Like every good thing comes to an end, so does this event today. So may I request Ms. Khushbu Sharma, Joint Director at Voice of Healthcare, Head Industry Collaborations, Outreach and Partnerships at VOH, to give the word of thanks. One of the most difficult part of every event, you see.
VOH from Voice of Health.
Thanks, Jyoti. Thank you so much. I align by each and every word that you just mentioned about how fantastic this panel was. To begin with, I would like to express my utmost gratitude to the entire faculty who has joined us today, right from 4 p.m. onwards. We've had the honor of having Ms. Aditi ma'am joining us. We've had the honor of having Dr. Daksha, Mr. Haryan, Dr. Naveen Nischal inaugurating this entire discussion. We have had the honor of having the panel which was led by Dr. Parekh, where the entire panel talked about infertility, inclusivity, and the stigma around it, and leading towards this fantastic panel led by Dr. Mansukhani. Once again, we are immensely honored to have such a reputed faculty with us. And I would like to also mention to all our faculty members that we have had an enthusiastic participation from our audience. We have had people joining in numbers to this discussion, to such an informative discussion, and all kudos to all your informative discussions that just happened. And towards the end, my entire gratitude to the Jaslok and team who have partnered with us and gave Voice of Healthcare this opportunity to stream this and make sure that we reach to the right set of audience. Thank you, Jyoti. Thank you, Hiral. Thank you, Dr. Sachin, for seamlessly coordinating and making sure that this amazing faculty joins us today. Thank you so much once again. And I really hope that we continue such associations and continue these discussions just towards the view of public health awareness. Thank you so much.
Thank you. Thanks, Hiral. Your name was not mentioned.
Mentioned.
Hiral.
Okay, I am
Dr.
joining.
Sachin. Thank you guys for hanging out till so late.
It's not on mute. We are not
Very
on mute.
nice.
No, he's just muting it.